Well, good day, everybody. This is Chris with the Ancient Scholar, and today what I'd like to do is I'd like to talk about one of the newer supraglottic airway devices out on the market. And this is a device from the company that makes the LMA, the laryngeal mask airway. And if you're aware, this is the more of the traditional LMA design. And the LMA basically has a little cuff. Okay. The tip is to be positioned in the proximal esophagus, and then the cuff inflates around that and creates somewhat of a seal, and then you have this opening here, and the opening is open toward the glottic aperture. So if you take a look at the airway here, see if I'll bring this down a little bit and focus that. So if you take a look at the airway, you can see that I have the esophagus here that we're looking through, and I have the glottic aperture here. And when properly positioned, the LMA, the tip sits right in the esophagus, and you can see that the opening of the LMA is open toward the glottic aperture. And that creates a conduit for air to pass in and out through positive pressure ventilation, or perhaps even spontaneous respirations or ventilations. Now, the LMA is an effective device. There's a lot of literature out on it. It's a very commonly used device in the operating theater and even in the pre-hospital environment. However, there are some potential disadvantages to the traditional LMA type devices, and some of the disadvantages include that you can have perhaps a higher risk of aspiration, even though the literature doesn't necessarily suggest that at all. But you can get some aspiration occurring around the cuff. The seal really isn't designed for higher airway pressures. And if you have a patient who wakes up or has seizing or some sort of voluntary or involuntary masseter action, you can potentially bite and compromise the tube or compromise the airway, or perhaps even break the airway. So there are some potential disadvantages of the classic LMA design or laryngeal mask design. And the newer design that's out is something known as the LMA Supreme. And the LMA Supreme has a cuff that is very similar to the classical LMA, but it has been redesigned. It has a couple of several different innovative advantages or possible advantages over the classical LMA design. The first advantage is it is tough. It has a hardened design, and it's particularly hardened over area where the teeth will sit, and it produces they've produced a bite block to prevent the tube from being compromised. It also has kind of this bent curve shape to it, and it is a little bit stiffer, and it is less likely to roll up on itself than the classical LMA, which does have a tendency to kind of flip over and occlude itself during insertion. Okay. In addition to that, one of the other innovative techniques is, you can see I have two different ports. I have a port for ventilation, and I have this gastric port here, and they have built in what they call their second seal, which is the distal tip, which, like the classical LMA design, sits in the esophagus, but the distal tip has a little hole, a little opening, a passage that communicates right here. So what does that allow you to do? Well, that allows you to pass a catheter through the device, through this port, and into the stomach, and allows you to decompress the stomach, which may decrease the risk of aspiration somewhat by being able to decompress the stomach. You're also potentially able to ventilate your patient at higher pressures. And the risk of having the patient bite or occlude the airway is decreased as well. In addition, the risk of the cuff flipping up on itself is also decreased a little bit, potentially at least. So the way this device works is, you have several different sizes. This just happens to be a 70 to 100 kilogram patient. and you inflate it with less than 45 milliliters of air, or if you have a cuffulator or cuff pressure device, less than 60 centimeters of water pressure in the cuff. So the way that this works is you go ahead and you take it out of the package, you set it up. I have to do this one-handed, so excuse me. Obviously, you're having somebody manually ventilate the patient, or perhaps this is a can intubate, can't mass ventilate situation, and you're using this as a primary backup to salvage your airway, or maybe you're just using this as your primary airway. Okay, so you go ahead and lubricate the distal tip. All right, and then you go ahead and position your patient. Let me just position. All right, pull back a little bit if I can. Okay, I'm going to take the device and I'm going to insert it. And unlike the LMA, I don't necessarily have to stick my finger in the patient's mouth to prevent the device from flipping up. I'm going to go ahead and insert the device, and what I'll do is I'll insert it until the bite block is between the teeth, or the teeth rather, are on the bite block, and this little part here is close to the lips as possible. I insert it, and what I'll do is I'll kind of reach a point where I get some definitive resistance. I'll then go ahead and inflate the cuff. All right, and I'll attach my CO2 detector. Of course, you should be using that. And you'll begin ventilating. And you can see with ventilations, let me pull back a little bit here, I'm getting a good lung rise and fall, at least on this airway mannequin here. Like I said, in addition to being able to ventilate potentially at higher pressures, I have that second seal option where I can go ahead and drop a gastric tube and decompress the stomach to, one, allow me to potentially ventilate at higher pressures, allow for better lung expansion, and two, to potentially prevent or reduce the risk of gastric aspiration. Okay guys, I hope you enjoyed this video, and this is a video on the LMA Supreme, and this is a device that you may see used out in the pre-hospital environment. In fact, the primary pre-hospital service in the area where I work has just recently transitioned to the LMA Supreme as their primary backup airway. As always, thanks for hanging in there.